In the lungs, there are a couple of different places where we see the most common problems. And the one that probably we've heard about most are in the airways. So this is this big fork looking thing. And those are the main airways to each of our lungs. And when there are problems with the airway, those diseases are most commonly asthma and chronic obstructive pulmonary disease, or COPD, bronchitis, which is a relatively common infection that we see in kids a lot. And then if it continues to happen over time and into adulthood, sometimes that's called chronic or consistent. It's a consistent disease, bronchitis. And then emphysema. So 3 of these diseases, COPD, bronchitis, and emphysema, are all relatively commonly associated with smoking, and that's pretty well known. And asthma can be associated with smoking as well, because when we smoke cigarettes, there are actually a number of toxins directly in the cigarette that can cause asthma to flare up. Lung tissue can also be affected. So the lungs themselves, where I showed you those little balls called the alveoli, that tissue can be affected by a couple different things. It can be directly attacked by our own immune system, and those diseases are called pulmonary fibrosis. And then there are other ways for that tissue to get scarred or hurt over time, sometimes by diseases that leave material behind. And so those are diseases like tuberculosis or sarcoidosis, where we can see balls of disease created over time. COVID can affect all 3 of these different types of lung disease. So it can affect the airway, and it can trigger asthma, it can make COPD worse, and it can also trigger emphysema to get worse over time. COVID can also directly damage the lung tissue. So those are the small balls, the alveoli that I showed you on the last slide. And that can affect our ability to either get oxygen into our body or to get carbon dioxide out of our bodies. And the last way in which it can affect our lungs is through the circulation. And so those are the blood vessels that take blood to and from the heart and to and from the lungs can be affected. And I think one of the more common things that we've heard about with COVID happening is blood clots. And those blood clots can happen anywhere in the body, but blood clots happening in the veins and the arteries that take blood to and from the heart has unfortunately been one of the more common complications that we've seen with COVID. And over time, a lot of those blood clots can actually increase the problems that we have with our lungs' ability over time to do their job. So I thought it would be interesting. One of the studies that we do most often in our clinics and our hospitals is actually a chest x-ray. So this is where we just do a radiograph of the chest itself. And I thought it would be interesting to walk through this together of what are the parts that we're looking at in the lung and why do they matter. So this is the airway here, traveling right down the middle of the chest. And then down here, it splits into that fork in the road that we saw here on this last image. So here, that fork in the road is right about here on the chest. And so in some folks, what we worry about is if this is blocked for any reason. Sometimes that can be mucus. And so in people with chronic bronchitis, or sometimes if you get food down the wrong pipe, that's something we call aspiration, where if you're accidentally getting food or water into your lungs rather than into your stomach, we can see that material blocking the airways on either side of the chest. Usually those happen even further out than that first branching. So then the next area that we worry about is the lung tissue itself. And so anywhere here that's these black areas are the air-filled lungs. And so if these areas turn white, we start to worry that there might be something like an infection or like scarring that's happened over time. And unfortunately with COVID, what we're seeing is that the lungs all over the place, sometimes we used to see a pneumonia or still do, that's just in one part of the lung. But if someone has had COVID for a very long time, then they start to get disease or white spots all over the sides of their lungs. And that's a sign of that scarring that's happened over time. And the last piece of this puzzle that from the last slide is that the blood vessels can also be affected. And the blood vessels are much harder to see on a chest x-ray than on some other types of scans like chest CT scan, so a CAT scan of the chest. But we get some ideas based on the size of the heart. So the heart is right here. We can just make out the border of it all throughout the middle of the chest. So sometimes the heart gets larger because it's working harder in order to maintain good oxygenation for the lungs. And sometimes we start to see a little bit of whiteness on either side of the chest here. That shows us that the blood vessels are a little bit too big, and they're bigger than they should be for a person based on these blood vessels here. The blood vessels all travel right alongside the midline of the chest. So this is this curve right here at the bottom is the diaphragm, which is the big muscle that's responsible for really helping us maintain our ability to breathe in and out. But in general, if you have old scar tissue, our bodies are very good at sort of leaving old scar tissue alone. And it's rare for that scar tissue to become a problem when you have an infection. I'm guessing what that person meant is that if you have scar tissue already, that's a part of your lung that's already been vulnerable. And so it might be hard for the rest of your lungs to compensate or to do the work of that part of the lung for it. If you were to get a very severe case where you have scarring over time with COVID. Unfortunately, not everyone gets, COVID that sticks around for a long time, and most people are not having COVID infections that cause bad scarring, especially with the vaccine now out. We're able to prevent those severe cases in most situations. But I'm guessing that that person was saying that the lung is more vulnerable overall because there's a part of it that is not doing the work of exchanging oxygen for carbon dioxide.
Dr. Suri, could you take a second and just explain how much lung tissue you need to adequately have good oxygenation? Like someone might have part of a lung taken out, and can they still breathe fine? And, do you need all of both lungs, I guess is what I'm asking.
I love that question. It's a really important one. So no, you don't. Most humans can do actually quite well even with one lung. So in some lung cancer surgeries, they'll take out an entire lung. And so people will have one side with no lung and one side with a full lung. And even that full lung might have some damage or some scarring, and they can often do very, very well. Even in lung transplants, sometimes only one lung is transplanted. So overall, you need less than half of your lungs in order to maintain normal oxygen levels. And if you have less than that, then sometimes people will need oxygen support or ventilator support. And sometimes you can see that here in the neck with what's called a tracheostomy for support. But definitely, it's a really, really critical question that we don't need all of our lungs. We have a lot more than we need, which is a really helpful thing, especially when we get sick. With one lung, I've seen people do amazing things. Half of one lung, I think it would be challenging. But I think with one lung, we've seen people have very good functional outcomes where they're able to live normal lives. From here, what I wanted to start talking about a little bit was chronic obstructive pulmonary disease, or COPD, which is one of the most common lung diseases that we see here in America. So I wanted to walk through a couple of the causes and some of the circumstances in which this is more common than others. And one of those, I think what we hear about often is smoking use. So smoking use, the more somebody smokes, the longer time that they've smoked and the number of packs that they've smoked in that time are the two factors that we think about in how high someone's risk will be for developing COPD. A couple of other very important causes or risk factors for COPD are pollution, which unfortunately we've learned over time that the way that we have allowed for waste and for burning of waste over time has disadvantaged certain communities over others. And oftentimes that does happen along racial lines, and it historically has. I think nowadays our states and our cities are doing better and better at recognizing and changing that, but certainly it's thought to be one of the causes of childhood asthma, especially in certain communities that often tend to be along racial lines. Chemical exposures are another risk factor for development of COPD, and those can be exposures at work, especially with certain types of stone. So sandblasters are at risk. Certain folks who work in caves can be at risk. And then coal miners are some of the more common, but other exposures, including military exposures, can often also cause lung disease in the long term, especially if people were exposed over a long time. There's a genetic disease up here on this board called AAT deficiency. It's alpha-1 antitrypsin deficiency. And the reason that becomes especially important in lung disease is because it also can be linked with a liver disease. So cirrhosis of the liver or scarring of the liver and scarring of the lung can both be more common in people who have this specific enzyme deficiency called alpha-1 antitrypsin. And the last one up here is a risk factor is chronic bronchitis. So having repeated infections over time, especially when they are under or untreated, can cause the development of this type of lung disease. Now with COPD, what we often see is that at an early stage, we can make a lot of movement, especially with things like pulmonary rehab, which is a specific type of rehab where we work with patients to build up their lung capacity over time and to try to get them back to a place where they're able to breathe comfortably and normally with the help of inhalers and other medications. COPD can progress over time, and it can get to the point where we start even at an extreme thinking about transplant if someone meets the criteria for that and their disease is so severe. But for most patients, COPD can be very well managed with rehabilitation and inhalers and sometimes oral medications as well. And sometimes antibiotics if they were to get an infection or a flare-up of the COPD. The next disease that I wanted to talk about for a minute is asthma. So asthma, again, like COPD, is extremely common. And asthma is a little bit different than COPD because in COPD, we know that over time, the lungs start to get bigger and bigger as they try to build up enough, bring in enough oxygen and let out enough carbon dioxide. But in asthma, instead of the lung tissue over time getting a little bit different, the airways become reactive. So that means that when you breathe in like an allergen, if somebody has bad seasonal allergies, they get a big breath of pollen, the airways they start to tighten. And in tightening, it makes it a lot harder to breathe. So that's also sometimes what you hear about with exercise-related asthma, is those muscles are very quickly tightening. And ideally, with the use of an inhaler, they're able to release that tightness quickly as well. Sometimes what can happen is that the airway actually tightens and then there's some swelling. And that swelling makes it challenging for someone to breathe well, even after they have loosened up a little bit, even after the muscle has loosened up. And when that happens, there can be a little bit of mucus that clogs it, or somebody can need steroids, especially if it's a brief, if they've had, a quick exposure, oftentimes they're able to release it quickly as well. But if somebody gets sick with a cold, or there's a long-term exposure to something like pollen, or if they have, a chemical exposure that makes their asthma really bad, so their airways are reacting. Sometimes people need short courses of steroid treatment. So that's something called prednisone is most common to get them through that inflammation. So to decrease the swelling in the airway. Asthma, like COPD, is very treatable and oftentimes is just treated with an inhaler that's used as needed. If someone's having more frequent issues, then we start to treat them with daily inhalers, and sometimes those are twice a day, depending on the situation, that keep the swelling and keep the inflammation at the lowest point possible for that person. And then we can also give inhalers that are called rescue inhalers that are used to relax that airway if they were to get tight based on a trigger. But asthma is especially common, and I think we hear about it all the time with kids too. I'm guessing Mandy has some experience with asthma, especially as the camp nurse right now. Lots of kids with inhalers, right? Yep. And especially in the summertime with a ton of pollen around, it can make it, really hard for kids to get asthma attacks and need those inhalers more frequently. But there are definitely more treatment options that we can use if somebody is having a lot of those attacks. Mandy, anything you'd add there?
No, I think for the summer for the kids, it's a lot of outdoor play in the heat and hard running, because the kids get very competitive with one another in a really good way, but it can be tough for a few of the kids here and there.
For many kids, and even in teenage years or young adulthood, it's common to have a few years of bad asthma. And in kids, we call it growing out of their asthma, which is incredibly common. And then in adulthood, sometimes it's just a few triggers that really can cause bad asthma, but otherwise someone is totally fine. And so that's a great point that you've made, that sometimes for people it's very scary and can be very severe for shorter periods or with specific triggers. But otherwise, in the long term, sometimes people totally grow out of it and don't need any treatment in the long term. And so with asthma, a couple of these severe symptoms are breathing very quickly. So breathing like at a rate, if you were to count how many breaths somebody is taking in a minute, more than 25. If they're breathing that quickly, sometimes that's a trigger for concern. Having trouble getting in a good breath of air. So to be able to go like this, sometimes that becomes very tough. And sometimes you can actually hear a wheeze. So that's a high-pitched sound that sounds a little bit different. It doesn't sound like a normal breath. And when you can hear that, that's quite concerning. Having pain in the chest with breathing is another concerning sign, where especially if it feels like it's squeezing. That can happen with asthma, but that can also happen with heart trouble, which is why it's really important to seek care if you or someone you know were to have those symptoms, to find out where that pain is coming from, or if it's potentially even both. Similarly, having a very fast heartbeat down here in the bottom right corner can be a sign that somebody is not able to get enough oxygen into their blood from their lungs. And a fast heartbeat can happen from a lot of different things, but it can be one sign that someone's not able to get enough oxygen. Specific to asthma, having nighttime episodes, so those episodes where the airways constrict and cause somebody to have a lot of trouble breathing quite suddenly sometimes, especially at night. So people who wake up coughing in the middle of the night, that can be a sign of an uncontrolled asthma, and maybe they need more treatment in order to better manage. And similarly, having a chronic cough for, on the order of weeks to months can be a sign that someone needs to seek care. This can be really common after a viral infection. So certainly with COVID, but really with any virus, including the flu or the common cold. Having a cough for a month afterwards is quite common. But if cough is persisting past that, or if it's happening without a specific trigger, it can be a sign that something is going on underneath.
I think it's really difficult when the person themselves becomes very frightened.
Mm-hmm.
And that can make it worse. So there's an emotional component for some people too.
Definitely. Thank you so much, Mandy. That the brain-lung connection is real, and it can start to cycle. Whereas if you get really nervous, having trouble breathing can make us nervous. And that nervousness can actually stop us from taking good deep breaths. So just like you said, that can be sort of a vicious cycle of not being able to breathe well, because when we're having trouble breathing, it does inspire a certain emotional and physiologic, our bodies know what to do, and that what they do is make us breathe even faster. Starting to talk a little bit more about what can we do to protect our lung health. One thing I wanted to spend a few minutes talking about was lung cancer screening. So this is something that I am really passionate about, and I'm guessing Dr. Liao is too, because he's a primary care doctor too. So making sure that we're getting people screened for lung cancer is a critical part of our work as primary care doctors. So in order to be eligible for lung cancer screening in the United States, based on our current guidelines, these screenings are for patients between 50 years of age and 80 years of age who either currently are smoking or smoked in the past, smoked in the last 15 years. So if you quit up to 15 years ago and you're 50 to 80, you are eligible for lung cancer screenings. And then the one other piece of data that we look at is the number of packs per day that were smoked and the number of years that were smoked. And we multiply those two numbers. So if you smoked 1 pack a day for 10 years, we consider that to be 10 pack years. If you smoked a half a pack a day for 40 years, that's 20 pack years. And so if you have 20 pack year history of smoking, that would qualify you for lung cancer screening as well, if you're 50 to 80 and you were smoking within the last 15 years.
There's a question in the chat. So someone who is asymptomatic but fits this profile would be screened, correct?
Definitely. And that's exactly the patient we want to be screening. We want to screen people who don't have symptoms, who are not having trouble breathing, who have not noticed that they're having more trouble with their daily activities, because we can watch. Sometimes patients, it's relatively common to have little spots on our lungs. And so if you have a spot on your lung, one of the things we do with these screening tests is we watch them over time. And so the goal is that we don't miss something that's growing over time, and we can treat it early, because many of these, if there is a small cancer, those cancers can be treated with much less early on than it takes later on, when those cancers have grown or are bigger and have spread to other parts of the body. So it's very similar to colonoscopies, where our goal is to treat earlier rather than later. And unlike a colonoscopy, there's no preparation involved. I think this is my last slide. So a couple of the things I wanted to talk about just briefly about how we can prevent lung disease. And certainly not all lung disease is preventable, but these are some general practices that we know impact our lung health. And so to your point just now, thank you so much for asking the question about secondhand smoke, because certainly we know that it is as cancer causing as smoking cigarettes oneself. And so minimizing smoke exposure, including secondhand smoke, is absolutely key. The next point I wanted to make is about avoiding toxic exposures as we're able to. And again, some of these will be in the environment, so it's really challenging to not have any exposures at all. But these are things like chemical fumes, solvents, paints, dust, and smoke. Staying active 30 minutes a day, at least 5 days a week, is a way for us to be exercising our muscles and to make sure that over time the diaphragm does not weaken, that muscle right at the bottom of the lungs that helps us get air in and out. Staying up to date on vaccines so that we can have vaccine preventable diseases. And that includes absolutely things like COVID-19 and the flu, where getting vaccinated dramatically decreases your risk of long-term effects. So long-term scarring from COVID-19 goes down with vaccines. And so for patients right now, the way that we talk about the number of shots to have is at least 3 shots. So the 2 is the series, plus a booster is the 3rd shot. And then for patients over 50, we've now recommended a 4th shot as well. And so if you're in any of those categories and still are looking to get vaccinated, most of our community sites, including CVS and Walgreens all over the city, are still doing free vaccines. Getting screened, like we just talked about, if you qualify for the lung cancer screening, CT scans is a critical part of this puzzle as well. And then I just want to say, especially during the pandemic, most of us avoided going to the doctor and seeking care for what seemed like maybe more routine issues or things that weren't bothering us too much. But for people who are having trouble breathing, a cough that won't go away, or pain and tightness when breathing, it's really, really important to be seeing your primary care doctor and having a discussion about getting, diagnostic testing done and trying to figure out what's going on, because many of these lung problems, like we talked about, are very, very treatable. And so having a doctor who's in it with you and working to figure out what's going on is an absolutely critical part of keeping you healthy in the long term.
Quick question.
Please.
I came after the first 10 minutes, so if this question were asked in the very beginning, I apologize. But I was curious as to whether different types of smoke impact lung disease. For example, some people might not smoke cigarettes, but they're into cigars, or they're smoking quite a bit of marijuana. And I wanted to know, when you're talking about 20 pack or 10 pack year, like, does it matter what type of what you're smoking, whether it is cigars, marijuana, cigarette, or even those vaping?
A lot of these decisions about who should get screened and when, at the highest level, the government is making this recommendation because of the trends that they've noticed in terms of lung cancer. But you're making a really great point about the fact that nowadays people are smoking more than just cigarettes. So these guidelines are for cigarette smoking specifically, but cigar smoking, marijuana are both risk factors for development of lung disease in the long term. And that can be things like chronic obstructive pulmonary disease and cancers both. Although marijuana has been a little bit more variable in terms of what is inside of the marijuana, because it's not regulated in the same way. So it's harder to say if all marijuana will or can cause cancer or not, in the same way that we know what's in cigarettes. Your question about vaping is also really important, because vaping can cause a different type of lung injury. So it does have some of the same toxic molecules that can cause cancers in the long term, but fewer of them. But unfortunately, some of the solution, so some of the liquid that's actually in the vape pen solution, can cause a different kind of lung injury, and that's something called valley or E-valley. So vape-associated lung injury is unfortunately becoming more and more common, especially in kids. So if you notice, if you have kids in your family or in your neighborhood who are vaping a lot and they suddenly have a lot of trouble breathing, that can be one of the things that's going on. It's this newer defined pathway of things called valley and E-valley. So some of them can have different presentations and the diseases can be a little bit different, but definitely all deserve conversations with the primary care doctor about who should and should not get screened for lung cancer.
Thank you very much, Dr. Suri. We really appreciate you spending your time and sharing your expertise with us also. And in 2 weeks, we will have another Heal 2 talk on primary care and what you can ask and get out of a visit to your primary care physician.